Hey guys, hope you're all well. This is the Gastroenterology tutorial. And just a quick notice that if you've got any questions relating to the tutorial as it's going that's relevant, please put it in the chat box, and any general questions, put it in the Q&A. So I'll just pass over to Mrinalini to give you the tutorial.
Hi guys, so today I'm just going to quickly go through. It's mainly going to concentrate on liver and the large bowel. So I'll be going through briefly about the anatomy, then the functions, as well as the pathology of each of these organs. So I'm going to start off with the liver. Okay, so this is just going to be a really brief outline of it. So your liver is located on the right side of your body underneath the lower ribs, and you have your falciform ligament over here. This separates the right lobe and the left lobe of your liver. And each lobe of the liver is separated into discrete segments with its own blood supply and own bile drainage, and I'll come onto that later on. Then you also have your quadrate, caudate, right and left lobes, and these are just 4 other lobes that they can ask you during SBA questions and exams and stuff to label them. Okay, so with your blood supply of the liver, you have your hepatic artery, which is oxygen-rich blood, which comes from the heart, and this is about 25% of the blood supply to the liver. And you have a right hepatic artery, which goes to the right lobe, and left hepatic artery, which goes to your left lobe. Then you have your hepatic portal vein, and your hepatic portal vein, essentially this carries your nutrient-rich blood from your gut. So this could include things like raw nutrients. It would also have bacteria and toxins and waste so that the liver can excrete it. And then finally, you have your hepatic vein, and your hepatic vein leaves the liver and it connects to your inferior vena cava, which goes back to your heart. That's really brief, but Grey's Anatomy goes into a lot more detail about it, which I think is better to go through that later so we can concentrate more on the physiology after. So you have something known as your hepatic lobule. And your hepatic lobule is essentially like a structural unit of the liver. This contains your central vein in the middle over here, and this central vein collects the blood which drains into your sinusoids, so that's this purple bit over here. And then you have your portal triad, which consists of your hepatic portal vein, your hepatic artery, well, a branch of either of these, and your bile duct as well. And so over here, these little cells over here, these are mainly your hepatocytes. And your hepatocytes make about 60% of the bile. The other bile that is made is by your cholangiocytes, which are like the cells that surround your bile duct over here. So that makes around 40% of the bile. And the important thing to note over here is that your bile is flowing outwards, whilst your blood and in your hepatic portal vein and hepatic artery are both going inwards towards your central vein. I hope that all makes sense. Okay, so your hepatic acinus, this is like your functional unit of a liver. So it is 1/6 of the part of 2 adjacent lobes. So essentially it's this bit, this whole diamond shape over here, that's one acinus. And you have different zones. So you have zone 1, zone 2, and zone 3. Your zone 1, it's the closest to the portal triad, and therefore this zone would receive the most oxygen, and it would be least affected by ischemia. So let's say the patient would have a condition that causes hypoxia, such as right-sided heart failure. This would mean that zone 1 would be least affected because it's the closest to this portal triad, so closest to the hepatic artery. But zone 3 would be the most affected because it's the furthest away. On the other hand, you have your toxins and your toxin risk. So let's say the patient has a paracetamol overdose. At that point, because zone 1 again is the closest to the portal triad, it's most at risk for damage from these toxins, whilst zone 3 would be least at risk. And I've got all of this written down in the notes as well, if you guys want to go through it again. Okay, so the liver functions. The liver has loads of functions, and I'm going to go through it depending on the type of cell and what that function does, what that cell does. So you have your hepatocytes, which are majority of your liver cells, and these are involved with carbohydrate metabolism. So this could be storing glucose as glycogen. It could be breaking down glycogen and using that using the glucose, so that's glycogenolysis. It could be gluconeogenesis, which is essentially producing glucose from amino acids and lactate, and it could be glycolysis as well. Then the hepatocytes are also important in the synthesis of amino acids. So there are two main, one example of them are transaminases. So you have your ALT and your AST. So in the hospital and stuff, when you want to find out about the liver function or the baseline, how the liver's working and stuff, you order a standard LFTs. So part of the standard panel of LFTs, you measure your ALT. And let's say it is very high. At that point, it would indicate towards maybe a liver injury, let's say. And this is because these enzymes are found in very high concentrations within the hepatocytes. Therefore, if the hepatocytes are damaged, it must leak into the blood, and therefore you would have a very high concentration of this in the blood, which would be picked up on the blood test. And the amount that these are raised, that can give some indication as to the cause of the damage. So let's say the ALT and AST are in the thousands, that is leaning more towards like an ischemic cause or a viral cause. However, these aren't completely great with actually knowing the exact function of the liver, only because let's say the damage is really, really bad, and at that point, your LFTs may not be raised that much. And the reason is because your liver does not even have that capacity to increase the number of enzymes that are produced. At that point, they would produce, let's say, the normal amount or even less than the normal amount. So therefore, instead of just solely relying on these, what they also look at is albumin. So your liver, another function of that is to synthesize albumin. And it's a very good indication of the liver function, because if you have very low albumin, that could indicate that there's very poor synthetic function in the liver. And albumin is really important in maintaining your osmolality and also transportation of various hormones, one of which we'll come on to later on. You also have your lipid metabolism, which happens in your hepatocytes. So that's producing lipoproteins and your cholesterol. And then you also, the liver also synthesizes proteins, which are involved in the immune system, like CRP and complement proteins. And there's also bile production, which we've already just gone through. There are also synthesis of hormones, for example, your IGF, your thrombopoietin, and angiotensinogen. So IGF, it's really important for your growth. Thrombopoietin is really important for your platelet production, and angiotensin is involved in your blood pressure regulation. And your liver also synthesizes clotting factors. So this can mean that, again, you can use, like I said about your albumin, you can look at that when you're looking at the function of the liver. You could also look at your INR, which is like your prothrombin time, and that would give you a very good indication of the liver function, because if it is prolonged, it means that it's taking longer for your blood to clot, which may point towards a deterioration in the liver. So what they do is they look at all three of these things. So they look at your LFTs, they look at your albumin, and they also look at clotting factors. Sorry, I just saw this question. Yeah, you just missed the bile production. No, bile production I'm going to go through later on. It was just the anatomy that you missed and a bit about the hepatocytes. but I've got all of this written down in the notes section anyway, and I can go through it at the end if you want. And don't worry. Okay, so you then go on to your stellate cells. So these basically store your vitamin A in little droplets. And these are very important cells to consider when you look at liver injury, because they're the main driver for hepatic fibrosis. So I will be going through this whole process later on anyway, when I go talk about cirrhosis in the liver. You also have Kupffer cells, which essentially phagocytose bacteria, and also therefore they're really important in detoxification of the different products that come from your portal vein. And they also release cytokines, and these cytokines released will then activate your stellate cells. Are the liver cells in a random arrangement? No, so your liver cells are arranged like this. So if you can see all of them, they're kind of arranged together in like hexagonal arrangements, and there's loads of different hexagonal arrangements like this that come together. So they all kind of like go in like the circular arrangement around the central vein over here, if that makes sense. Over here I've added like metabolism videos for the different functions of the liver that I've just gone through, because we won't have enough time to go through all of this. And these are really good ones that give a very short summary. And this is the summary of your ornithine cycle, because one of the functions of the liver is to metabolize amino acids, which the liver converts from ammonia to urea. So that will go through that in a lot of detail. Are the liver in terms of hepatocytes, stellate cells, and Kupffer cells? So basically with the arrangement, you just have the odd Kupffer cells on the edge of the, over here in the portal triad, you have the Kupffer cells found on the edge. So over here, so can you see how, and you also have them in the sinusoids as well. So it's the yellow bit over here. So you find them in the edges and in the sinusoids. And with your stellate cells, I think it's majority your hepatocytes are everywhere, and then you just have stellate cells like oddly rearranged in them amongst the hepatocytes. Okay. So we're gonna go through 2 questions now. If you guys wanna vote for this one, what separates the right and left lobe of the liver? Okay, there we go. And I'll give you guys like a minute. Wait, can you see the voting? Like which one is being voted for? Okay, let me try and okay. 20 out of 24. Okay, perfect. Okay, I'll just give you guys a few more. I think everyone's voted and polling. Okay, yeah, all of you guys got it right. I think that was probably quite an easy one then. Okay, this is the second question. Which zone of the liver is most risk at damage from the toxins? Okay. There we go. So that was a 50-50 split on zone 1 and zone 3. And the place which has at most risk from toxins is actually zone 1. And the reason why is because it's the closest to the hepatic portal triad, and therefore any toxins that will come through will reach zone 1 first before they go to zone 3. I hope that makes sense. If it doesn't, just message me and I'll go through it again. Okay. Okay, so your bile. Your bile, it is made out mainly of your bile salts and your bile pigments. So with your bile salts, this is the major component of bile, and it could involve things like your cholic acid. And these bile salts are really important because they emulsify your fats. And the way they do this is because they're amphiphilic. So that means that one part of them is hydrophobic, the other part is hydrophilic. And therefore, this allows the fats to be easily digested and absorbed by your small bowel. You then, so the way the whole emulsification, all of that works is when you eat any fatty food, this stimulates your small bowel to secrete an enzyme known as CCK. And this enzyme stimulates your gallbladder to contract. And your gallbladder is where your bile is stored. It's also acidified and concentrated in the gallbladder as well. And therefore, let's say the gallbladder has some sort of pathology. So there are gallstones or the gallbladder is inflamed. At that point, you might need to remove the gallbladder, and that process is known as a procedure is known as a cholecystectomy. And when this does happen afterwards, because they won't have a gallbladder, there is an issue with the storage of bile, and therefore patients don't really need to follow a really special diet as such, but it is really important that they avoid very fatty foods and they maintain this healthy diet. It becomes even more critical at that point. And one of the risk factors anyway to get like gallstones and inflammation of your gallbladder, known as cholecystitis, is obesity. The other component of bile is your bile pigments, and these bile pigments are essentially your conjugated bilirubin. So your bilirubin, okay, there we go. So bilirubin is essentially, it comes from your broken down red blood cells. And these broken down red blood cells release hemoglobin, and this is eventually you want to excrete this in your feces. So what happens initially is you have either extravascular or intravascular hemolysis, the breakdown of red blood cell. This causes the release of heme, and then eventually this becomes unconjugated bilirubin. This unconjugated bilirubin then binds to your albumin and then moves on into your liver. And in the liver, there's the unconjugated bilirubin is conjugated, and the way this is done is through an enzyme known as UDPGT, which is like uridine 5-bisphosphogluranol transferase. After this is done, then the conjugated bilirubin would enter the biliary system, which I'll go through next. And then the biliary system, in the biliary system, it can either be excreted as your stercobilinogen, or it could be recycled back into your liver, and that recycling is known as your enterohepatic cycle, and then I'll go through that again later on. Or it could be excreted through your kidneys as urobilinogen in the urine. The stercobilinogen is what makes your feces brown, and the urobilinogen is what makes your urine yellow in color. Okay, so the biliary tree or the biliary system is this. So you have your right hepatic duct and your left hepatic duct, and both of these combine together to form your common hepatic duct. Then you have your cystic duct, and which comes from your gallbladder. This combines with your common hepatic duct to make your common bile duct. Your common bile duct and your pancreatic duct join together at the ampulla vata, and then over here you have a sphincter. This sphincter is quite important because it can dysfunction, and when it does dysfunction, it causes the bile to go back up into either this biliary system over here, or it can cause the bile to go back up into your pancreatic duct. And let's say it does go back into your pancreatic duct, at that point it could cause pancreatitis. I've got a link in the notes section that will go through in more detail about this sphincter and what happens when it dysfunctions, but that's a very brief outline. Then you have your enterohepatic circulation. So your enterohepatic circulation is really important with the recycling of bile salts, and it's quite useful because it essentially, to make your bile, it requires a lot of energy, and this is because making cholesterol needs a lot of ATP. Therefore, by recycling them, it essentially just saves the energy. So the way the bile acids are recycled is by them being reabsorbed in the gut into the bloodstream, and through the hepatic portal vein they can re-enter the liver. What role does the ampulla vata have in the biliary in relation to the biliary tree? It essentially is just this bit over here, and at the end of it you have your sphincter, and the sphincter just allows the bile and the pancreatic enzymes to enter your duodenum. I don't think it has a more predominant relation. It's not in this diagram, but it would be over here. And the issue with your enterohepatic circulation is that there are certain drugs that your liver would try to excrete. However, due to this circulation, these drugs can stay in the liver for can stay in the body for longer because they are reabsorbed by the portal vein and come back into the liver, and then through the liver, through the hepatic vein, they could be recirculated around. Okay, one sec. I'll see if there's any questions I've missed. What is the difference between primary and secondary bile salts? I don't know that much about them, but I think, as far as I can remember, your primary bile salts are the ones that are made by your blood, but your secondary ones are the ones that are like due to the things that happen in the colon. So your colon has your gut bacteria, and I think they are to do with your secondary bile acids. That's what I believe, but I think if you remind me at the end, I can come back to that after having a look at it. But I'm pretty sure primary are the main ones that are synthesized by the liver, and that's the one that you should concentrate on for this. Okay, so jaundice. Jaundice is essentially the yellow discoloration of your sclera and your skin, and this is due to high bilirubin. And normally jaundice, like the level of bilirubin can be up to 20.5. However, as soon as you go above that, then at that point you start, it starts being excess, and above a level of 35 micromoles per liter, at that point you would notice this yellow discoloration. You have your three different types of jaundice. So you have prehepatic, is 20.5 micromoles per liter. I've got it written down in the notes as well. The exact ranges as well for the bilirubin. You have your prehepatic jaundice, your hepatic jaundice, and your posthepatic jaundice. So your prehepatic is due to excess hemolysis. So this is when your red blood cells break down, and this causes an overproduction of bilirubin. And this can be due to many reasons. So for example, it might be due to infections such as malaria. It could be due to sickle cell anemia. It could be due to thalassemia. So basically anything that could cause an issue with your red blood cell may cause them to break down, and therefore you would have excess bilirubin. And this bilirubin that you would have an excess of would be mainly unconjugated bilirubin, because it is in your liver where the bilirubin is conjugated. You have your hepatic causes, and this could be things like your hepatic causes could be things like your hepatitis, hepatocellular carcinoma, metabolic problems such as your Wilson's disease. It could be drugs like paracetamol. There's another syndrome known as Gilbert syndrome, which is when you have a deficiency in the UDPGT, so the enzyme that conjugates bilirubin. And all of this basically causes you to have a mixed picture. So you could either might have an increase in unconjugated and conjugated bilirubin because it's a hepatic cause. Then you have your post-hepatic. So your post-hepatic causes are anything that are to do with the obstruction or outflow of your bile. So basically anything that's blocking your biliary tree. This could be things to do with like gallstones. It could be cancer at the head of the pancreas. There's other conditions which cause inflammation of your biliary system, such as primary sclerosing cholangitis, which you guys will learn mainly in year 3 in your clinical years. And with your post-hepatic, it's mainly unconjugated bilirubin, which is increased. And with post-hepatic, the important thing is if this is the cause, the patient would have pale stool and dark urine. And the reason why is because your stercobilinogen, the thing that I went through previously, is over here, is what gives the feces the brown color, and urobilinogen is what gives the urine the yellow color. So therefore you would have pale stool and dark urine if there's any if it's a post-hepatic cause. Okay, so liver disease. Your liver can be damaged by many things, and this is just a very brief list of them. And any of these things damaging the liver would give rise to loads of signs and symptoms. It can be very vague as well. It could be very vague, like your general malaise, just generally feeling very unwell. You might feel very itchy, and the itchiness is actually mainly due to your bile salts, which kind of like cause your skin to become very irritable. Increase in bruising. There's something known as spider nevi, and this is essentially like your central arteriole over here, and they have pneumal vessels which kind of radiate outwards from here, and these are mainly found on your abdomen and your chest. And up to 5 is fine, but more than 5 is when there is, like, you might be thinking there might be some pathology. You have something known as your Dupuytren's contracture, which is when you have thickening of the aponeurosis over here. Ascites, essentially fluid accumulation in your abdomen. Jaundice will go as we've just gone through. And there's something known as your asterixis, which is when, in this image, as you can see, the palms are out like this, and there's kind of like a flap which the patient will show, and this is done without them realizing. You can see this more clearly when the patient closes their eyes. What is NASH and AI? So NASH is non-alcoholic steatohepatitis. So this is mainly the inflammation of the liver due to the diet that the people follow. So it's linked with obesity. And AI is autoimmune hepatitis. So there's certain antibodies that you can test for to see whether there is an autoimmune cause, but this is mainly like a diagnosis of exclusion. And I've got in the notes section a long list of other signs and symptoms that you can see. These were just a few of them. Okay, cirrhosis. So cirrhosis, this is basically the end stage of your chronic liver damage, and this is when it is irreversible, so you cannot go back to the normal healthy functioning liver after this stage is hit. And it's mainly characterized by jaundice, bleeding in your gut, ascites, and encephalopathy. So this is when you have buildup of toxins such as ammonia in your brain, and that can cause things like your asterixis, so the flap over here. And over here, this is quite important at this point to go back to your stellate cells, because they have the main role in this fibrosis and cirrhosis. So with your stellate cells, usually they store vitamin A. But let's say when the liver your liver has started to become damaged, at that point they secrete something known as tumor growth factor beta. And this produces collagen in your extracellular matrix and in your fibrotic tissue. This fibrotic tissue can then compress on your sinusoids, which can increase the pressure, causing portal hypertension. And this increase in pressure can lead to fluid being pushed out of the peritoneal cavity and causing ascites, one of the things that liver cirrhosis is characterized by. There is also something known as hepatorenal syndrome. And with hepatorenal syndrome, it is when the cirrhosis eventually causes your liver to fail. Your cirrhosis, cirrhosis eventually causes your kidneys to fail. And this syndrome is quite awful at this point because they are in a lot of pain, and with the kidneys failing, they are required to be on a lot of different drugs and stuff for this. And I've got a detailed explanation as to why the liver causes the kidneys to fail, and I can come back to it at the end, but just in case we run out of time, I'll move on for now. Okay, so what biliary duct drains bile directly from the gallbladder? Let's open the poll, launch polling. Okay, so I'll share the results. Most of you got it correct. Yeah, it is cystic duct. I can go, let me see if I can go back to show why for the people that didn't. There we go. So over here, the rest of you that said common bile duct, the common bile duct is when your cystic duct and your common hepatic duct join together, and that's when you form the common bile duct over here. And then the second question, which one of the following is a prehepatic cause of jaundice? This is quite a hard one. Okay, and share results. Okay, so those of you that said thalassemia were correct. And so the first two, viral hepatitis and alcohol, those are mainly the hepatic causes. The gallstone and chronic pancreatitis, those are your post-hepatic causes of jaundice. Thalassemia causes excess hemolysis, which is why it is a prehepatic cause of jaundice. There we go. Okay, does anyone have any more questions before I move on about the liver? Okay, I guess that's no. I'll move on then. Okay, so this is a diagram of your large intestine, and it starts at the end of your ileum and then goes all the way down to your anus. It's around 1.5 meters long and 6 centimeters wide. The cecum and appendix over here, these are in your right iliac fossa, and you have your ileocecal valve over here. So this stops your gut bacteria from entering your ileum, but it allows your chyme, so basically your digested nutrients, to enter your cecum and enter the large bowel. You have your ascending colon over here and your descending colon over here. These both are retroperitoneal structures and they're found in your flanks. You have your right colic flexure, also known as your hepatic flexure up here, and your splenic flexure up here. Then you have your transverse colon. Your transverse colon is basically the least fixed part of the colon, and the position of this can be variable. So, for example, it can dip in to the pelvis in really tall and thin individuals. And unlike the ascending and descending colon, the transverse colon is intraperitoneal, so is enclosed by your transverse mesocolon. And then you have your sigmoid colon over here, which is an S shape, your rectum, and finally your anus over here. And your anal canal will consist of two sphincters, your internal and your external, and I'll go through those two in more detail later on. Sorry, what does the valve do? So it's quite important. So for the nutrients from your small bowel to enter your large bowel, you want the nutrients to enter from your small bowel to your large bowel, but you don't want any of the gut bacteria or the nutrients to go back up into your small bowel. So essentially the valve is there to stop the gut bacteria from entering the rest of the gut. And then over here, and in the notes, I have more about the function of the appendix, because before they thought it was useless, but recently they think that the appendix is where there's a storehouse for gut bacteria. It's also needed in the rebooting after like diarrheal illnesses. There's loads of different potential causes of what the appendix might be there for, which I've got that down in the notes. Okay, so then you have the muscles of your gut. So basically you have your longitudinal muscles, which are your tinea coli, and you have your circular muscles, which is your inner layer, and that's over here. So your tinea coli, your longitudinal muscle, that is shorter than the length of the colon, and therefore this causes your large bowel to pouch. So as you can see over here, it pouches, and these are known as haustra. And you also have something known as your appendices. I can't really pronounce this correctly, but yeah, that is basically your fatty tags. And these are small pouches of the peritoneum which are filled with fat, and they're situated along your colon, but they're not really there in your rectum. The function of these are largely unknown, but Some people think they might be there for the colon being cushioned during peristalsis. Others think it might be there to help the colon absorb nutrients. It's really unknown as to why people have these. However, sometimes these can become inflamed, and at that point it can cause the patient to present with abdominal pain. Okay, so the blood supply. Your ascending colon and the start 2/3 of your transverse colon come from the midgut. So this is all to do with the embryological origin of this. And your last third of the transverse colon, descending sigmoid and rectum, all of that comes from your hindgut. And because of that, the blood supply is as it is. So you have the start, all of this is supplied to by your superior mesenteric artery, whilst the rest of this is supplied to by your inferior mesenteric artery. And over here I've got like the specific, over here is labelled as the specific arteries which supply each bit. The important thing to note is that there's something known as the marginal artery, which is essentially when and this is really clinically important because it coalesces it combines both of these arterial supplies, so basically it makes it form like this sort of continuous loop. And this continuous loop is quite important because let's say you have an occlusion over here or an occlusion here. At this point, because it is in this continuous loop, even though you have this occlusion or like a stenosis in this artery, the rest of the gut would still get blood supply because of this sort of anastomosis over here. I hope that all makes sense. Is all of the transverse supplied by the middle colic, or is it the first 2/3? So yeah, it's only the first 2/3 which is supplied by your middle colic artery, and the last third is supplied by your left colic artery. Okay, so then you have your the venous drainage, and with this, your ascending colon drains through your ileocecal and right colic veins, which empty into your superior mesenteric vein, whilst your transverse colon is drained by your middle colic vein, and this also empties into your superior mesenteric vein. Your descending colon is drained by your left colic vein, and this drains into your inferior mesenteric vein. And your sigmoid colon is drained by the sigmoid veins, which again drain into your inferior mesenteric vein. And the superior and inferior mesenteric vein both eventually empty into your hepatic portal vein, which goes back into your liver. Okay, so the large bowel has a variety of functions such as the reabsorption of water and electrolytes. However, the small bowel does absorb more water than the large bowel. Also elimination of waste and undigested food. And there is also a microenvironment for the gut bacteria. So to start off with, the motility. So there's loads of different sort of contractions that can happen in the large bowel. You have your basic contractions, which are kind of like, which moves the chime about 5 to 10 centimeters per hour. So this allows more time for absorption. You have your antipropulsive contractions. This impede the movement through the colon. So these are contractions that force it towards the ileum rather than towards the rectum. You also have segmentational or haustral contractions, which shuffle the contents back and forwards. And along your haustra, there are cells known as pacemaker cells. These cells send signals to your smooth muscles in the wall and cause them to contract. And these contractions allow the food to be churned. And by this food churning, it increases the gut contents so that it has a larger surface area. And therefore this can maximize the absorption. And these pacemaker cells, as you are closer to the ileum, they emit signals which is faster than those closer to the rectum, And the reason because of this is because it allows there to be a gradient. So there's a gentle progression of bowel contents towards the rectum. You also have short propulsive movements, and the frequency of this increases after a meal, but these short propulsive movements only happen every 30 minutes or so. And there's also these coordinated mass movements. And with these coordinated mass movements, these are very intense and they're not really seen anywhere else in the digestive tube. It only happens 1 to 3 times a day. And this involves very sudden uniform peristaltic waves, which is basically the contraction of the smooth muscles of the gut that starts at the transverse colon and it moves rapidly towards the rectum. And this allows the contents to move 3/4 of the way along the large bowel in a few seconds. And high fiber foods promote this. So by that, the reason why is because the high fiber foods kind of bulk up the contents, and because of this bulking up of the digested food, it creates more of a pressure on the walls, which allows them to allows the coordinated movements to be promoted. Okay, does the marginal artery come from the superior, inferior? Not sure how it relates. See, that's with the marginal artery. I think it's just where, not like it's coming from one or the other. I think it's just where both of them join. Not sure how it relates. So the reason why it's quite important is because if these two arteries are joined together, so the branches from the superior mesenteric or inferior mesenteric, they all anastomose together to form this sort of loop. If there was, let's say, an occlusion over here in your right middle colic, or let's say in your superior mesenteric, at that point all of this part of the gut won't get any blood supply. However, with this anastomosis over here, it forms this loop, which means that even though there's an occlusion over here, the blood can drain all the way from here and can still supply to this part of the gut, if that makes sense. Out of interest, how long is this? The lecture should finish hopefully in about another 10-15 minutes, I think. Okay. Ulcerative colitis. So ulcerative colitis, this is when it's a chronic relapsing and reemitting inflammatory disease of the large bowel. It starts in your rectum and it spreads proximally. This is always continuous, and it usually stops at your cecum. However, some patients have something known as backwater ileitis, which means they have some irritation in your ileum due to the ileocecal valve being incompetent. So with your ulcerative colitis, the reason why this is linked to the motility is because the colonic motor activity is usually frequently abnormal in patients with ulcerative colitis, and overall majority of the data suggests that patients that have ulcerative colitis have increased intraluminal load, which basically means that there's increase in your propulsive activity, so increase in all of this motility stuff, and therefore patients with ulcerative colitis often present with diarrhea, and how often they go to the toilet can somewhat relate to the how bad the ulcerative colitis is. And here are just a few other signs and symptoms of UC. Okay. So, which of the arteries supply the start of the transverse colon? Let's see if I can put this poll on. 5. Launch. Okay, I'm going to end it there. Share results. Okay, yeah. So it's right colic and middle colic artery. I can go back to the diagram. 1 second. So over here, this is the transverse. It is applied to by the right colic and middle colic over here. Okay, which one of the following colonic contractions do high fiber food mainly affect? And this is a final question of the session. Polling. Okay, I'll end it there. Okay, I guess this was a bit of a harder one. It's coordinated mass movements. Technically, high fiber foods, they will help with majority of this, but it's mainly coordinated mass movements, and that's because of the bulking causes the increase in the distension of your large bowel, because fibers, when you have a high fiber foods, that would essentially bulk the feces, and therefore this bulk the chyme, and therefore this increase would allow the wall to be more distended, which would allow the coordinated mass movements, which would affect the coordinated mass movements more than the other sort of contractions. Stop share. Okay. So the rectum, this is responsible for your temporary storage of feces before defecation. And in your rectum, you have your internal sphincter over here, and this has autonomic nerve supply, and whilst it has your external sphincter over here, which is supplied by your somatic nervous system, so that is your pudendal nerve. So your internal sphincter, so the way defecation, the whole process works, is known as something known as your rectosphincteric reflex. So you have mass movements, which causes the feces to enter the rectum, and from the sigmoid colon. The rectum then distends due to the increase in intrarectal pressure. This is detected by the pressure receptors in the rectal wall. This then sends the information down the sensory nerves to the spinal cord, where it then sends the information to your afferent nerve fibers of your pelvic nerve, so your parasympathetic nervous system, which then sends the signal to your internal sphincter and the smooth muscles of your wall. So it causes your internal sphincter to relax. However, it causes the wall of the sigmoid and rectum to contract. And let's say at that point you don't want to excrete, then your there is voluntary contraction of your external sphincter. So the sphincter over here will contract, and this would basically hold in and so stop you from defecating until the next mass movement happens. But let's say it is appropriate. At that point, your external sphincter would relax and you can defecate. And your external sphincter is supplied by your pudendal nerve, which is controlled by your cerebral cortex, which is why you can control when you want to go and when you don't want to go. Okay, so fecal incontinence, this is when this is due to many reasons. So for example, it could happen when the sphincters are damaged or the nerves are damaged, which you would lose which nerve supplies which sphincter again. So your internal sphincter is supplied by your autonomic nervous system, so your pelvic nerves supply your internal sphincter, and your external sphincter is supplied by your pudendal nerve, which is your somatic nervous system. The childbirth, it could be also due to severe hemorrhoids, other conditions which affects the nerve, such as strokes, diabetes. Some children are born with an abnormal sphincter, and there's also inflammatory bowel disease or irritable bowel syndrome, so your Crohn's disease or irritable bowel syndrome, which can cause your bowel to become overreactive. And at this point, it can cause fecal incontinence as well. And there's a wide variety of symptoms, treatments, such as you can change the diet. There are certain drugs that are helpful when the bowel squeezes too strongly. So, and there's also exercise, and surgery as well can be done in certain conditions. For example, if the patient has hemorrhoids, at that point, if they're very bad, they can have a hemorrhoidectomy, which is essentially just removing the hemorrhoids. And there's more information on the different sorts of treatments in more detail in the notes section, but because it's already 8, I will go on to the next slide. Okay, so specialized cells. The colon has many enterocytes, which have short irregular microvilli over here, and these are really important in the role of reabsorption of electrolytes. You have imagination, so that's this bit over here, which are known as your colonic crypts or your crypts of Leiberhan, and these crypts at the bottom, these crypts mainly contain your glands and your mucus-producing goblet cells. These are quite important because they protect your intestinal wall from anaerobic bacteria in the colon, and also from the pressure that's exerted on the wall by the chyme. Also, it facilitates the passageway of the dry luminal contents. So therefore, as you go along the colon, so towards the rectum, there is more goblet cells, there are more glands, because the contents will get more and more dry as you go along the colon. And your walls also have some lymphoid tissue as well in there. And there are also stem cells right at the bottom, which are there to replace the cells that are lost at the tip. Okay, so reabsorption. You have your sodium, which can be reabsorbed by the sodium hydrogen antipore. So the whole point of this is to reabsorb water mainly. So your sodium, this is reabsorbed by a sodium hydrogen antiporter on the luminal membrane, or they are co-transported with glucose and amino acids, which basically move the sodium from your lumen into your enterocyte. This sodium can then be rapidly absorbed into your bloodstream by a sodium-potassium pump. And essentially this maintains this gradient through the sodium-potassium pump, allows it to maintain the gradient of sodium. Then you have your chloride ions, which are reabsorbed, and the reason why is because of the electrochemical gradient that's formed from the reabsorption of the sodium ions. When your chloride ions are reabsorbed, bicarbonate ions are exchanged with the chloride ions, therefore your bicarbonate ions are pushed out into your lumen. Because of these electrolytes, there is an osmotic gradient which is created, which allows absorption of water. So you have aldosterone, glucocorticoids, and stomatostatins, which all increase the net absorption of water, and the way they do this is by increasing the action of the sodium-potassium ATPase, so your sodium-potassium pump on your basolateral membrane of the enterocytes. Cholera. Okay, so this infection basically causes very severe diarrhea, and the way this is done, very briefly, is due to the cholera toxin. This binds to the receptor. It activates your adenylate cyclase, which then causes an increase in cyclic AMP, which results in an increase in CFTR, which pumps out your chloride ions. So the chloride ions are pumped out. This then causes your sodium and your water, therefore, to follow with it. And this loss of water and electrolytes therefore cause you to have watery diarrhea. It would also cause severe dehydration in the patient. They would, because of this dehydration, they would have a low blood pressure, a rapid heart rate, and because these electrolytes are lost, the patient may also present with muscle cramps. Okay, this is the final thing we're going to go through, which is your gut bacteria. And I've gone into a lot of detail in the notes section, but to briefly summarize the gut bacteria, it's really important in digesting certain substances in the chyme which are not digestible by the human digestive system. It's important with your bacterial fermentation. The bacterial fermentation causes the production of vitamins such as vitamin K, vitamin B1, vitamin B2, B6, B12, and even biotin. And vitamin K is the main one, which is produced only by the gut bacteria. And vitamin K is essential for the clotting of the blood. There's also production of short-chain fatty acids, such as butyrate. And basically, there have been loads of randomized control trials which have shown that higher productions of these short-chain fatty acids by your gut bacteria correlates with lower diet-induced obesity and also reduced insulin resistance. And also, as a byproduct, there are certain gases produced, such as carbon dioxide and methane, by bacterial fermentation, which leads to gas, basically. And there's loads of twin studies which show that the microbiome, it is not just it's not just influenced by your genetic factors, but also related to your diet, any drugs that you take, and also exercise as well. Let's say there's something that goes wrong with the gut bacteria. At that point, it's related to various things such as insulin resistance, it's related to things such as inflammatory bowel disease, psoriatic arthritis, and there are even studies which show that it is related to sleep. However, the exact mechanism of how is not completely known yet. Okay, so these are just a few takeaway messages. The liver has various functions such as carbohydrate metabolism, synthesis of proteins, synthesis of clotting factors, detoxification, and due to these wide variety of functions, it can present with a huge range of symptoms such as asterixis, ascites, pruritus, which is itching, and general malaise. Jaundice is the clinical presentation of excess hemoglobin breakdown, and it could be not hemoglobin, it's meant to be excess bilirubin, and it can be split into prehepatic, hepatic, and posthepatic causes. You have your ascending colon and your proximal 2/3 of the colon, which is derived from your midgut, whilst your distal third and transverse colon, your descending and sigmoid colon, which is all derived from your hindgut, and this affects the sort of blood supply to them. And the functions of the large bowel include reabsorption of water, electrolytes, elimination of waste, undigested food, and a microenvironment for gut bacteria. I hope that was useful. This is the feedback form. And also let me know if there's any more questions on any of that.